In Japan, autologous bone grafting is the gold standard, but it is problematic because it creates new bone defects in the ilium and fibula where the bone is harvested. In addition, the surgery time is longer and the patient's surgical injuries, such as pain from surgery at the bone harvest site, increase in 2 places. The newly developed OCP is the final component of the artificial bone, and CT bone is a custom-made artificial bone that is 3D printed from the patient's CT diagonal data. The patient's X-ray CT data, DICOM, is imported into 3D CAD to design the external and internal structures. The CAD data is converted into STL data and transferred to an inkjet 3D printer to create a 3D artificial bone, CT bone. CT bone can not only regenerate the external shape in 3D, but also create internal bone structures with interconnected pores that allow easy entry of bone cells and blood vessels. This is a topological, geometric structure design that contributes to early bone replacement while maintaining strength. The starting material for CT bone is alpha-TCP. CT bone is shaped using a powder lamination method with an inkjet 3D printer. After shaping, it is recrystallized in an acidic solution of succinic acid to become calcium-deficient hydroxyapatite containing OCP. Unlike conventional high-temperature sintered stoichiometric hydroxyapatite and beta-TCP, this new artificial bone has the characteristic of being replaced by the body's own bone through the body's bone metabolism. OCP is the world's first crystal synthesized by Professor Monma more than 40 years ago. Scaffolds with shapes using OCP crystals as bone graft materials are difficult to manufacture and have never been commercialized. Next21 has succeeded in custom molding alpha-TCP using a 3D printer and mass-producing artificial bones using injection molding. We were able to recrystallize alpha-TCP in a weakly acidic dicarboxylic acid aqueous solution and create and shape bone grafts of any shape and internal structure. High-temperature sintered stoichiometric hydroxyapatite HA and CT bone formed by a 3D printer were implanted into the target positions of dog skulls, and bone infiltration into and bone regeneration of each artificial bone was observed. The size is a 15 mm by 15 mm square, and the CT bone has 3 communicating holes intersecting at right angles to guide bone marrow and speed up bone regeneration. In a comparative study of bone integration, hydroxyapatite showed insufficient fusion even after 24 weeks post-implantation, with a clearly visible boundary remaining between the graft and the host bone. In contrast, CT bone demonstrated early disappearance of the graft-host bone interface, indicating clear and timely bone integration. Furthermore, regarding cellular infiltration, no significant invasion of fibroblasts or bone marrow was observed in the HA group even after 24 weeks. However, in the CT bone group, fibroblast infiltration was already evident by week 4, and by week 24, bone marrow-like tissue had formed, with ossification progressing in a manner similar to the host bone. The X-ray absorption intensity, Hounsfield units, within each structure of the HA artificial bone and CT bone was measured over time to observe changes in the artificial bone. With HA, there was little change in the HU value and little bone infiltration, making it an inactive artificial bone. With CT bone, fibroblasts and bone marrow invade the communicating pores in about 2 weeks. In addition, bone infiltration into the artificial bone is about twice as fast as with HA. This means that with CT bone replacement progresses quickly and the strength of the artificial bone graft increases at the same time. In the case of apocerum, bone tissue was observed only in limited micropores located near the surface. In contrast, in CT bone tissue had infiltrated into deeper and interconnected micropores, and clear formation of bone tissue was confirmed. Furthermore, within CT bone, the formation of bone marrow tissue was observed, including erythroblasts indicated by blue arrows and megakaryocytes indicated by yellow arrows. These findings suggest that reconstruction of bone marrow structure with hematopoietic function is in progress. Newly formed bone tissue, shown in green, and fibroblasts, shown in blue, were clearly observed within the interconnected macroporous regions and also in the specific areas inside CT bone indicated by arrows. In addition, numerous adipocytes were observed within the interconnected macroporous regions. Moreover, the formation of bone marrow tissue was also confirmed, including erythroblasts, which correspond to the areas indicated by red arrows, and megakaryocytes, which correspond to the areas indicated by blue arrows. In the image on the left, fibroblasts and blood vessels infiltrating into the interior of CT bone were observed at the area indicated by the blue arrow. In the image on the right, osteoclast activity was observed on the surface of CT bone, at the area indicated by the black arrow. CT bone allows doctors to prepare an ideally shaped bone implant before surgery, so they can simply insert it into the defect during surgery. As a result, surgery time can be reduced by 3 hours. The implant was inserted without invading facial tissue. This allows for minimally invasive treatment for the patient. CT bone fits well into the defect and has excellent retention, so it was fixed in place by covering it with periosteum, allowing for good operability. The patient was discharged on April 8, 2006. Both the patient and their family reported satisfaction with the outcome of the treatment. Bone formation was quantitatively evaluated based on post-operative CT images. A 55-year-old woman with post-operative facial deformity was referred to the University of Tokyo Hospital. 20 years earlier, she had undergone partial glossectomy, segmental mandibular osteotomy, and 15 costal autologous cartilage grafts with pectoralis major myocutaneous flap. Follow-up evaluations showed that the patient's facial appearance improved aesthetically without any serious adverse effects. CT scans taken at 6 and 12 months after surgery confirmed partial fusion between the CT bone and the host bone. The patient's hemifacial microsomia was classified as unilateral Prusansky type 2. The mandibular deviation was severe and associated with malocclusion, which was treated with bilateral mandibular distraction, osteogenesis, and LaFour-1 osteotomy. 18 months later, right mandibular reconstruction and genioplasty were performed, using CT bone to correct the mandibular asymmetry. Follow-up studies showed that the facial aesthetics improved without any serious side effects, and CT scans taken 6 and 12 months later showed partial integration of the CT bone and the host bone tissue. CT bone fills the strong need for a less invasive and safer bone implant to replace autogenous and allogeneic bone grafts. Its features include a shape that precisely fits the bone defect, an open internal structure for cell infiltration, and an effective material for bone fusion replacement. If the shortage of human allogeneic bones in bone banks continues, crimes involving the theft of bones from corpses will increase. Theft of bones from corpses has become a social problem in both the United States and China. After acquiring the patient's bone morphology data using a CT scanner, the design is carried out in 3D CAD software using digital transformation technologies. In particular, the internal topology structure is optimized using artificial intelligence, or AI. The completed design data is exported in STL format and used by a 3D printer to fabricate the three-dimensional structure of CT bone. Afterward, the product undergoes packaging and sterilization before being shipped to medical institutions. CT bone is modeled using the principles of an inkjet printer, with multiple nozzles capable of spraying 4 to 5 different colored inks. It is possible to create 3D structures with any color, even inside the 3D structure. By applying this principle, it is possible to deliver the defect-inducing factors, FGF2 and VEGF, as well as the bone formation factors BMP2, RUNX2 plus AK6 in appropriate amounts to positions in the structure suitable for bone regeneration. Future research into early bone healing and bone replacement is anticipated. CT bone is an artificial bone, primarily composed of calcium phosphate. Its compressive strength is approximately 20 megapascals, placing it between beta-tricalcium phosphate and hydroxyapatite-based artificial bones. However, due to the inherent brittleness of calcium phosphate materials, there are currently no artificial bones suitable for load-bearing applications. To address this issue, reinforcement with titanium metal is required. In response, we developed and successfully commercialized hybrid bone, a composite that combines CT bone with a titanium ultra-flex mesh for enhanced strength and durability. Bone grafts are used in many medical departments, including orthopedics, neurosurgery, plastic surgery, cosmetic surgery, and oral surgery. Each medical department has different uses and objectives, but Next21 owns 5 core technologies for bone regeneration. We combine these technologies to supply graft materials so that each patient visiting each department can receive bone regeneration, bone reconstruction that is tailored to their needs,